You probably know someone who seemed perfectly healthy. They exercised regularly, avoided junk food, and followed medical advice carefully. Their annual checkups showed numbers within normal limits. Then one day, they experienced a heart attack unexpectedly. Stories like this feel confusing and deeply unsettling. We naturally assume heart disease targets only visibly unhealthy individuals. We imagine obesity, smoking, or extreme cholesterol levels must be present. But reality is more nuanced than that assumption. Nearly half of heart attack patients present LDL levels considered normal. That does not mean cholesterol is irrelevant. It means cholesterol alone does not tell the whole story. The real question becomes quietly important. If standard numbers look acceptable, what are we missing? Where does the true risk begin inside the body? The answer lies within the inner lining of your arteries. Arteries are not rigid pipes. They are living, responsive tissues. They react to inflammation, stress hormones, and metabolic signals constantly. Heart attacks rarely happen without years of microscopic changes. Those changes can develop even in disciplined individuals. Tonight, we will explore what actually happens inside arterial walls, not to create fear, but to build understanding. Because clarity is far more powerful than anxiety. Let us begin with something important about LDL cholesterol. LDL itself is not automatically harmful. Its primary role is to transport cholesterol to cells needing repair. Think of LDL as delivery trucks carrying building materials. Problems begin when those particles undergo chemical modification. This modification is called oxidation. Oxidation happens when particles interact with reactive oxygen molecules. These reactive molecules increase during chronic stress and inflammation. They also rise with smoking, poor sleep, and excess refined sugar intake. When LDL becomes oxidized, its structure changes subtly. It is no longer smooth and biologically neutral. It becomes more adhesive and more likely to irritate vessel walls. Imagine a clean tennis ball turning slightly rough and sticky. That roughness makes it easier to lodge beneath the arterial lining. The inner arterial layer is called the endothelium. The endothelium acts like a protective, intelligent barrier. When oxidized particles pass through this layer, irritation begins. This irritation triggers a mild immune response locally. Now here is the key distinction. Risk is not only about how much LDL circulates. It is also about how many particles become oxidized. A person can have normal LDL numbers, yet still experience higher oxidative stress internally. That combination quietly increases arterial vulnerability over time. This is why lifestyle quality matters beyond laboratory totals. The chemistry of particles often matters more than quantity alone. And oxidation is where the process truly begins. Once oxidized LDL slips beneath the endothelial lining, the body notices. Your immune system is designed to protect you from damage. It sends specialized cells called macrophages to investigate. Macrophages are the body's cleanup crew. They normally remove debris and prevent infection effectively. When they encounter oxidized LDL, they attempt to remove it. They engulf these particles in an effort to restore balance. At first, this is a healthy protective response. But unlike normal LDL, oxidized LDL is harder to regulate. Macrophages continue consuming these particles without strict limitation. Gradually, they fill with lipid droplets internally. At that stage, they transform into what are called foam cells. Foam cells accumulate within the arterial wall quietly. This accumulation forms the earliest stage of plaque development. Over time, more immune cells arrive at the site. Inflammation increases in that small localized area. The body attempts to contain this inflammation safely. It builds a fibrous cap over the growing plaque. For years, this plaque may cause no symptoms at all. Blood flow can remain largely normal during early stages. The real danger arises if the fibrous cap weakens. Inflammation can thin this protective layer gradually. If the cap ruptures suddenly, blood contacts the inner plaque core. The clotting system activates immediately to seal the rupture. In certain arteries, that clot can block circulation entirely. This is how a heart attack often begins. Not always from gradual narrowing, but from sudden plaque rupture. The immune system's protective response becomes part of the problem, and this process can occur even in disciplined individuals. Now we shift from cholesterol to something less visible. Inflammation is often the quiet driver behind plaque instability. Inflammation is not always harmful. It is part of your natural repair system. When you cut your skin, inflammation helps healing begin. But chronic low-grade inflammation behaves differently. It simmers quietly inside tissues for years. Stress, poor sleep, excess sugar, and pollution can sustain it. When inflammation persists, endothelial cells become more fragile. They lose some ability to regulate vascular tone properly. They also produce less nitric oxide. Nitric oxide keeps vessels relaxed and flexible. Reduced nitric oxide makes arteries slightly stiffer over time. Inflammatory signals also attract more immune cells locally. This amplifies plaque growth and destabilization gradually. Even small inflammatory elevations can matter long-term. This is why doctors measure markers like C-reactive protein. C-reactive protein reflects systemic inflammatory activity. High levels suggest the immune system is constantly activated. Importantly, inflammation can exist even with normal cholesterol numbers. A person may look lean and physically active, yet chronic psychological stress may still elevate inflammatory tone. Inflammation weakens the fibrous cap, covering plaques. It degrades collagen that keeps plaques structurally stable. A thinner cap is more vulnerable to rupture. When rupture occurs, clot formation can be immediate. So, the true issue is rarely a single factor. It is the interaction between cholesterol, oxidation, and inflammation. Understanding that interaction reduces confusion about healthy heart attacks. Because heart disease is often a process, not a sudden event. There is another process that changes arteries quietly over time. It is called vascular calcification. Arteries are meant to remain elastic and responsive. With each heartbeat, they expand slightly to absorb pressure. That elasticity protects delicate downstream vessels. But chronic inflammation can alter this flexibility. Smooth muscle cells inside arteries begin changing behavior. They start behaving more like bone-forming cells. Calcium gradually deposits within arterial walls. This does not always block the artery immediately. Instead, it changes the mechanical properties of the vessel. A flexible artery becomes more rigid and brittle. Imagine a rubber hose slowly turning into ceramic tubing. Ceramic tubing cannot absorb sudden pressure changes well. Rigid arteries transmit pressure more forcefully with each heartbeat. That mechanical stress increases strain on plaque surfaces. If plaque is present, stiffness raises rupture risk further. Calcium can also accumulate within existing plaques. This can make plaques harder, but sometimes more unstable. Stability depends on how calcium integrates into the structure. Research increasingly shows calcification predicts cardiovascular events independently. Importantly, calcification can occur even in physically active individuals. It does not require visible obesity or poor fitness. Dietary imbalance and micronutrient deficiencies may contribute. Vitamin K plays a role in directing calcium appropriately. When regulation fails, calcium drifts into soft tissues. Over years, arteries gradually lose youthful elasticity. No symptom announces this transition clearly. Blood pressure may remain within acceptable ranges, yet structural resilience has quietly declined. Understanding mechanisms is useful, but action matters more. You do not need advanced laboratories to improve vascular health. Start with sleep, because inflammation often begins there. 7 to 8 consistent hours stabilize stress hormones significantly. Chronic cortisol elevation increases oxidative stress inside vessels. Next, reduce refined sugar and ultra-processed carbohydrates. Excess sugar increases glycation and promotes LDL oxidation, Whole foods lower oxidative burden and stabilize insulin response. Regular resistance training improves endothelial nitric oxide production. Nitric oxide keeps arteries flexible and responsive. Even brisk walking after meals improves vascular function measurably. Stress management is not optional in cardiovascular prevention. Chronic psychological strain sustains inflammatory signaling silently. Simple breathing practices reduce sympathetic nervous system overactivation. Dark leafy vegetables provide nitrates and antioxidant compounds. These compounds support endothelial repair and reduce oxidation. If possible, discuss expanded lipid testing with your physician. ApoB reflects particle number more accurately than LDL alone. High sensitivity CRP reveals systemic inflammation levels. These tests are helpful, but lifestyle remains foundational. You cannot supplement your way out of chronic stress. You cannot outrun persistent sleep deprivation indefinitely. Healthy appearance is valuable, but internal chemistry matters more. Cardiovascular risk is about stability, not perfection. Most heart attacks develop over decades quietly. That means prevention also works gradually and powerfully. The goal is not fear, but clarity and consistency. When you understand the mechanisms, your choices become strategic, because heart health is less about luck and more about maintenance. And maintenance is something you can control daily.